So, quite a lot of overlap between what I'm going to say and what Jelani said. Of course, we know that there's an association between increased nucleotranslucency and major congenital heart disease. And the incidence of congenital heart disease will increase as the nucleotranslucency increases. Notice that the group of patients between the 95th and the 99th centile, this group here, there's 4 times as many patients in that group than there is in all these other 4 groups. So, in fact, this group, although they're at quite low risk, they're about double the background risk, there's quite a lot of patients in there. Now, I'm not suggesting that all these patients need a fetal echocardiogram, but they need special attention to be paid to the heart during the routine obstetric scan. I think probably we should continue to look at this group with a fetal echocardiogram, but because they are at higher risk. But this group is numerically very large. Now, the first suggestion that major congenital heart disease was associated with an increased nucleotranslucency came from John Hyatt, working at King's in the 1990s. And he suggested over half of neonates with major congenital heart disease had an increased nucleotranslucency. But there have been 2 studies since then, both with reasonable numbers, but both hospital-based. So there were non-selected series, low-risk patients not coming to a referral centre, which, of course, John Hyatt was working at King's, so that was a referral centre. And they came out with very different figures, 13 and 17%. And it's very hard to fault either of these studies because they both seem to be correct. Whereas with John Hyatt's paper, his ascertainment was very low. So that suggests that he was missing a number of cases of congenital heart disease in his series that in fact did have congenital heart disease, but he wasn't ascertaining. So that's the criticism of this paper. But with the other 2 papers, really it's hard to see why they've got such a low risk of congenital heart disease. Maybe the numbers are just too small, but certainly they were getting ascertainment in about the range that you would expect. So about 3 per 1,000 major structural heart disease is about what you would expect. So basically, we still don't really know what proportion of cases of major congenital heart disease have an increased nucleotranslucency. Another study that came from several centres looked at congenital heart disease the other way around. So they collected a large series of cases of congenital heart disease, and then they found out whether they'd had nucleotranslucency screening and what the number was. And they found that 23% had a rate over an increased nucleotranslucency. The trouble is, when you look at their data, in fact, in the fetal series that they used, or the fetal cases that they used, many of the fetuses had been referred for increased nucleotranslucency, which, it takes away from the strength of the number of cases. So I don't know what the right answer is, but it's somewhere in this range rather than that range. So many cases of major congenital heart disease, maybe 1 in 5, is associated with an increased nucleotranslucency, but certainly not as many as half, is the kind of bottom line. Now, we've already seen from Jelani the difference in the size of the heart as gestation progresses. But of course, as you can see, and if you've seen from her very nice pictures, you can get superb pictures of the heart at this early gestational age. You can see from the kind of lumpy nature of the 2D image that it's very magnified, but you can still see the chambers very clearly, 2 nice ventricles flow into them, particularly using the colour is very useful. Origin of the aorta, pulmonary artery crossing over. So a nice normal scan with fetus in a good position. Of course, life's not always quite like that, but you can usually see the crux of the heart very clearly, offsetting of the AV valves, and you can compare that to an abnormal case where you're not seeing that nice intact crux. In fact, there's a big hole in the middle of the heart where the yellow dot is. This was a fetus with a nuchal translucency of 4.1, atrioventricular valve regurgitation, which is almost always a feature of an AVSD at 12 weeks gestation, and of course, not surprisingly, the diagnosis was trisomy 21. Here's another case where the diagnosis of an abnormality was obvious at 13 weeks, I think this patient was. Again, we're seeing a thickened small cavity right ventricle, poor contraction of the right ventricle, and on the colour flow map, there's filling of the left ventricle right down to the apex, but there's hardly any filling of this little right ventricle. And this is a typical case of pulmonary atresia with intact ventricular septum, quite a modestly increased nuchal translucency of 3.5, but the four-chamber view clearly looks abnormal, and it's a typical appearance of this important cardiac defect. In this fetus, she was less than 12 weeks, so the image quality of the 2D is very poor indeed. But as you can see, when you put the colour flow map on, you've got two parallel tubes coming out of the heart, which of course means there must be transposition of the great arteries. The nuchal was 7, transposition of the great arteries. We were too scared not to karyotype, although transposition of the great arteries is very rarely associated with karyotype abnormality. We felt we couldn't not karyotype this fetus with a nuchal translucency of 7.0. But in fact, of course, it was normal, and this was a typical transposition of the great arteries, no different from any other case of transposition of the great arteries that doesn't present in this way, went through pregnancy and had a satisfactory surgical repair after birth. But one of the first cases that we saw with parallel great arteries in the first, before 12 weeks. And as Jelani has also suggested, often because the person doing the nuchal scan is used to looking for the heart and at the heart during the nuchal scan, not uncommonly they notice when there's something wrong with the structure of the heart, particularly if they're trying to estimate the tricuspid valve for tricuspid regurgitation. And here we have a fetus with a normal nuchal translucency of 1.7, but the sonographer noticed the heart looked abnormal, and this was Ebstein's malformation of the tricuspid valve with quite a big right atrium already and a big heart already at 12 weeks gestation. Now, Jelani's briefly mentioned tricuspid regurgitation. This is something I started to notice in the about 2001. I noticed that one or two of the fetuses with increased nuchal translucency seem to have tricuspid regurgitation, which is not a common feature of the fetus. It occurs, but it's not very common, not nearly as common as it is in postnatal life. So we started to look at this in a more comprehensive way. It's important that you've got a good orientation to the tricuspid valve, that you put your Doppler sample volume across the valve itself and move it back and forward across the little valve and make sure that you're not finding anything, or make sure you're interrogating the tricuspid valve correctly anyway. This is an absolutely normal appearance when you get a sharp click, which is just your sample volume being affected by the cusp of the tricuspid valve itself. This is a completely normal appearance with this very sharp line immediately after the end of the AV valve tracing. So this is a valve click and is quite normal. But when you see a broader reverse flow, and it's higher velocity than the aorta, which is usually only about 30 centimeters per second at 12 weeks, whereas this tricuspid regurgitation often extends over 70 centimeters per second, or even is holosystolic, as we see here, and above 1 meter per second, this is real tricuspid regurgitation. This is just a little bit, but both have significance. Both seem to be associated with not only trisomy 21, but also with congenital heart disease. It's important to recognize, everybody said, well, why don't you just look with colour flow mapping? But actually, many of the machines, particularly older machines now, they're getting more sensitive all the time, so you can often see tricuspid regurgitation on colour flow mapping, but you can't rely on the colour flow map, because often we could see it on pulse Doppler, which is a much more precise measurement, but we couldn't see it on colour, particularly with the old machine. So I think it's important to actually interrogate the valve properly with pulse Doppler. And then the other thing to be aware of is that this is a transient phenomenon, and it's usually gone. It's usually gone actually by 16 weeks, but certainly by 20, which is curious but interesting. It's best seen on pulse Doppler, sometimes with colour flow. You've got to see a high velocity to confirm that it really is regurgitation. It often will predict chromosome abnormalities, but it's also associated with an increased instance of congenital heart disease, even without chromosome abnormalities. And 4% of our cases of tricuspid regurgitation have congenital heart disease when we review them later in pregnancy. And again, this is a transient phenomenon, usually resolves at the same sort of time as the nuchal translucency itself resolves. You rarely see it later on in pregnancy. An aberrant right subclavian artery is an important thing to look for in the fetus, as Rabi suggested to us just a few years ago, and I thought, oh, that doesn't sound as if it's going to be very useful. But of course, whenever you say that, you know it's going to come back and hit you. So he was suggesting in a very small series of Down syndrome fetuses that there was an aberrant right subclavian artery in as many as a third of them. Now, we knew that from old anatomical data, Jesse Edwards, for example, published a paper in 1953 telling us that about 1 to 2% of the normal population had an aberrant right subclavian artery. And also from old cath series, where children with trisomy 21 were almost routinely cathed looking for congenital heart disease, because it was before the days of echocardiography where you can make diagnosis of congenital heart disease in trisomy 21 or exclude it very easily. From the old cath series, they reported instance of an aberrant right subclavian artery was between 15 and 36%. So we started to look, now actually this is not me, but this is the fellows prior to CVS in the research room looking for aberrant right subclavian artery as well as other features. And they looked at 516 fetuses before the patient went on to CVS. In that initial series, they had 80 to 8% success in identifying the course of the right subclavian artery transabdominally. So pretty good success right from the even from the very early days. And they found an aberrant right subclavian artery in 0.6% of normals and in 8% of trisomy 21. Now, when we followed up that, and that paper was published a couple of years ago, when we followed up that series, we realized we'd missed a couple of aberrant right subclavian arteries in our normals, and we also had missed a couple in the trisomy 21 group when we looked at them later in pregnancy. So since we've added more recent data, what we're finding is that the presence of an aberrant right subclavian artery increases the background risk of trisomy 21 by about 10 or 15%. So a very important marker to look for, because if you've got a patient from their age, for NT, everything else, that has a 1 in 500 risk of trisomy 21, and when, of course, you wouldn't be offering her or suggesting an amniocentesis, if she's got an aberrant right subclavian artery, that increases it by 10, so that brings it down to 1 in 50. So a substantial change to her risk just from this feature alone. And here we're looking at 12 weeks gestation. The heart's down here in both fetuses, both lying in the same position with the left side down. And what we're seeing and I'm sure you're all saying, well, you can't see anything here. Well, on colour, this is the normal right subclavian artery. It's always this curvy structure here coming off above the level of the aortic arch. The aberrant right subclavian comes off lower and it goes behind the trachea. So even though your landmarks are really difficult to find, this looks quite different from the normal once you get used to looking for it. So a useful marker to look for in the early scan. Now, a paper came out of our department a couple of years ago looking at abnormal ductus venosus and suggesting that it increased the incidence of congenital heart disease by 3 times. It may be true, but I was very unhappy with the data, so I came out of the authorship because I find that you can't, in my hands anyway, about 10% of the time I'm not always able to obtain the ductus venosus. Now, maybe I'm not trying hard enough, maybe I'm not doing it long enough, but we do a lot of early scans and I wasn't able to be sure of it quite often. And at least 10% of the time I was absolutely unable to interpret the tracing. It's easy to interpret when it looks absolutely normal. It's easy to interpret when it looks absolutely abnormal. But quite often you have overlap of other vessels, which if you don't take your scale down, you don't necessarily appreciate there is in fact another vessel behind the ductus venosus here, which it's a hepatic vein, causing a bit of reverse flow overlapping and making your interpretation uncertain. And then what I found not uncommonly was that during the time of the scan, it sometimes looked pretty normal, it sometimes looked absent, and it sometimes looked reverse. Now, what do you call this? Normal, absent, or reverse? I didn't know what to call it quite frequently. So about 10% of the time, I couldn't categorize the ductus venosus. And this data was taken from everybody's categorization in a diverse group just from the routine room. So I felt that the data wasn't really, it was maybe correct, but it wasn't strong enough for me to join in with. So I have some reservations about ductus venosus. I think it's worth looking at and trying to sort out what it means, but I'm still not very sure of exactly what it means and how useful it is. The other thing we've looked at relatively recently is that there was a suggestion early on in the association between nuchal screening and congenital heart disease that left heart disease in particular was more common with increased nuchal translucency. So what we did was look at a series of patients, all with a normal karyotype, to see if there was a specific disease, a specific form of congenital heart disease that was more strongly associated with increased nuchal translucency. And we had quite a good number of cases of everything, about 120 of cohort, about 60 of hypoplast. It was a relatively short time period of about 2 years. 92, no, it must have been a bit more than that because there were 92 cases of transposition, 59 of ABSD, all with normal karyotypes, which is important to appreciate, and also tetralogy of Fallot. And more or less, they were all coming out about the 40%. But the important thing to realize that 40%, this figure doesn't really mean very much because some of our cases were referred for an increased nuchal translucency. What we wanted to look at was to see whether there was a form of congenital heart disease that was dominating, that was more frequently seen than you might expect in a normal series of congenital heart disease as a stronger association. But basically, we couldn't confirm that there was a higher rate of left heart disease. It may be that ABSD has a higher rate of increased nuchal translucency and that transposition is a little bit lower, but we can't tell that from a referred population, which of course we are always dealing with. Now, what are some of the disadvantages of early scanning? Well, it is a little bit harder work. You have to work at it a little bit harder. When I started doing it in the early part of the century, I felt as if I was back 20 years and trying to figure out what I was seeing at 20 weeks, as I was, which was my experience way back when I was starting. I had nobody else to ask, so I just had to figure out what I was seeing. I felt a little bit like that when I was trying to do it at 12 weeks at the beginning. It's harder work. You have to really look harder. We don't know very much about false positives. We have virtually no autopsy information from the patients that have an abnormal karyotype and go on to termination of pregnancy. We could very rarely get autopsy information. We have had some, and mostly it's been very consistent with our diagnosis, but we don't get much autopsy information, unfortunately. But in half the cases, we do have a later scan, and in that group, we nearly always are confirming within, with minor differences in diagnosis, we're confirming the diagnosis at a later scan, either of normal or of abnormal. So we're pretty sure that we're mostly getting it correct when we're seeing the fetus at 12 weeks. And the reason that I'm doing it at 12 weeks, maybe more than Jelani, is because I'm living in a fetal medicine department, so I'm always right there when the increased nuchal translucency is found. So I'm standing about with nothing else to do, so they might as well send me the patient on the way to CVS. So that's why I'm actually suggesting that the ideal time is to do it at the same visit, but then I'm sitting there in the same department, which Jelani isn't always. So that's why I'm getting all the patients before CVS rather than after CVS. As far as false negatives are concerned, we know that some more minor defects we probably overlook, but we've certainly had the same experience as Rabbi talked about this morning, is that he was finding something either subtly abnormal at 12 weeks or something that looked completely normal. And the evolution of the case by 20 weeks has turned into something unexpected. Like he had a completely filling left ventricle at 12 weeks, but at nearly 20 weeks it was a typical hypoplastic left heart. We've had exactly the same experience. I had a patient recently, just a little bit of MR at 12 weeks. MR is pretty unusual, but I've seen it before and it's gone away by 20 weeks. But this particular patient at 20 weeks, there's critical aortic stenosis. Looks completely different from the nice, pretty normal scan I had at 12 weeks. We've also seen coarctation develop where it absolutely looked normal, including the transverse arch at 12 weeks, and we've also seen it with pulmonary atresia, where we just had tricuspid regurgitation at 12 weeks and nothing else. But at 20 weeks, it was a completely developed pulmonary atresia with intact ventricular septum. Now, it's not common. We've done thousands of 12-week scans and had only a handful of progression. But it does occur, and it's something that you must be aware of, and therefore you should always repeat the scan. If you've done a 12-week scan, you should always repeat at 20 weeks. I think it's essential. So, just to summarise, increased nuchal translucency, of course, is an important high-risk group to be referred for fetal echocardiography. I think it's particularly important for the specialist to look at those with a nuchal translucency over the 99th centile, which is over 3.5. And if you look at them early, about a quarter, before CVS, about a quarter of them will have congenital heart disease. So that's a very high rate of yield. Mostly when you're scanning, you're going to find maybe 1 in 10, maybe 1 in 15 have congenital heart disease with your normal referral groups. But this is a very high-risk group where a quarter are going to have congenital heart disease. The 95th to the 99th centile, I think they should all be seen at 20 weeks. If your fetal medicine person is competent to look at the heart, there is no reason why the routine sonographer can't check the heart as part of their routine anomaly scan, but 2% of them have congenital heart disease. They are at slightly increased risk. You can accurately diagnose congenital heart disease at 12 weeks, and useful additional markers that can focus your mind on the heart and increase the incidence of congenital heart disease include tricuspid regurgitation, aberrant right subclavian artery, and possibly also ductus venosus. As I've said, we can't find a specific form of congenital heart disease that's specifically associated with increased nuchal translucency. Any form of congenital heart disease can present in this way. Beware of progression of congenital heart disease between 12 and 20 weeks, and something I haven't had time to touch on, we still don't really understand the mechanism which increases nuchal translucency in the first place. Okay, that's finished.